For the remainder of this video, we're going to focus on understanding how COVID spreads and what schools can do practically to minimize the risk of it spreading within the school environment. There's been a lot of research done over the last few years looking at how COVID spreads, and one of the things that's come through from that research very strongly is that COVID is an airborne virus. It is transmitted via the air that we breathe. COVID spreads via aerosols, which are microscopic particles produced all of the time while we're breathing. When a person with COVID exhales, they expel aerosol particles containing the virus into the air, and anyone who inhales these virus-laden particles can potentially be infected with COVID. Aerosols are not visible to the naked eye, so we have an immediate challenge, which is how do we identify when people are expelling COVID into the air via aerosols, and how do we know where those aerosols end up? Thankfully, there's been a lot of work done on modeling of the flow of aerosols within indoor spaces. I'm just going to show you a few seconds from a short video that illustrates, using a computer simulation, how an aerosol spreads from one person to others within a confined space, in this case a classroom. And so you can see the elapsed time here is 40 seconds, and already we've got a cloud of aerosols expanding throughout the poorly ventilated indoor space of a classroom. So we know that aerosols are produced by breathing. They're also produced by talking and singing. And I'm going to show you again a short part of a video, in this case created by the John Snow Project, which is a project led by a group of doctors and other experts who are producing materials to help people to better understand COVID. They've created this simulation to illustrate how aerosols spread in a similar way to cigarette smoke. They can travel long distances, they can accumulate in poorly ventilated spaces. So we know for a fact now that the vast majority of COVID infections are via inhalation and not via surface contact. This is a study that was published in April last year that showed that people are on average 1,000 times more likely to be infected via inhalation of the virus than by touching a contaminated surface. So for all of you that have got bottles of hand sanitizer and encouraging people to wash their hands, that's a good practice. Having good hand hygiene is a good practice for lots of reasons, but unfortunately it's doing very little and possibly nothing to prevent COVID transmission. So if we look at how COVID spread, there are two types of transmission, short range and long range. So if we look first at short range transmission, that's when people are in close proximity. It can involve large droplets, which would ordinarily fall to the ground, but if people are in close proximity, they can go from one person to the other, as well as aerosols of various sizes that can travel much further than the 2 meters that we often hear about when we're encouraged to socially distance. So social distancing is important, and we'll talk some more about that, but it's only important in reducing short-range transmission. So if we think about where does short-range transmission occur, well, it occurs anywhere where you've got people in close proximity. And in the school context, obviously that occurs in lots of settings, in classrooms and music rehearsals and assemblies and many other types of gathering. If we look now at long-range transmission, we can ask ourselves, where does it occur? Well, it occurs anywhere where the aerosols exhaled by one person can spread to other people. And this is typically in indoor spaces that are not well ventilated. It's important to note that anytime you have long-range transmission, you also have short-range transmission if people are in close proximity. So in a setting like this, in a classroom, you have the potential for short-range transmission between students and teachers that are close to each other, and the potential for long-range transmission across the room. We're going to talk some more about buses later under risk assessment, but buses are actually one of the least well-ventilated places that humans can occupy. Particularly the coach-style buses used by many schools for camps and excursions often have very limited fresh air intake and frequently are run with air conditioning systems purely on air recirculate. So they pose a very substantial risk of both short-range and long-range transmission. So it's useful to look at the different types of transmission in different settings in the school environment. So let's look firstly at outdoors. Outdoors, really the only significant risk of COVID transmission is short range. And in this diagram, you can see there's a dense plume of aerosols near the source, an infected student, but that plume of aerosols rapidly dilutes and disperses with distance, especially if there's some breeze. So the main risk of transmission is to those people who are in close proximity, including if they're downwind, if there is a breeze. So if we look at indoor spaces, let's look first at a well-ventilated classroom. And in this case, we have an infected student, and the student is exhaling a dense plume of aerosols that are concentrated near the source, but that dilute and disperse with distance. And the risk to other students beyond that short-range transmission is fairly low if the ventilation is enough to be able to dilute and disperse those aerosols quickly within the classroom. In contrast, if we look at a poorly ventilated classroom, what we can see is that there's still a high risk of short-range transmission because the infected student is still emitting that dense plume of aerosols containing COVID virus. But what we're also seeing is that that plume isn't dispersed and diluted throughout the space efficiently. And so you actually get a buildup of those infectious aerosols within the indoor space. And the longer that group of students stay in that space, the higher the risk of long-range infection of anyone else within that shared space. I'm going to ask you to start off with a thought experiment. So just for a minute, think about this question. Would you share a water bottle with every other person in your classroom? I'm going to assume that for most people the answer is no, you wouldn't. You would have lots of good reasons for not doing that, mostly to do with hygiene and not wanting to spread diseases or catch something that someone else might have. But what's really interesting is that when we share the air that we breathe, we're doing exactly the same thing, but just without physical contact. We're still inhaling particles that have been exhaled by all of the other people in a room. So given that we share the air that we breathe, it's worth taking a minute to look at how much air we actually share. So we know that over the course of a year, a typical student spends around about 1,000 hours inside classrooms and other shared school buildings. And in that time, they breathe around about 500,000 litres of shared indoor air. So we can see the importance of having air that is safe to breathe and that doesn't increase the risk of people acquiring airborne viruses like COVID. The reality is that there's no single thing that we can do that's 100% effective in preventing COVID spreading from one person to another. We really have to be looking at layered mitigations. And this is called the Swiss cheese model. Each layer of protection is something that we can do that has some positive impact, albeit imperfect. But when we add all of these layers together, we actually massively reduce the risk of COVID spreading. And in this diagram, we're looking at a number of different mitigations that we're going to talk about, including physical distancing and ventilation, CO2 monitoring, use of HEPA filters, use of masks, in particular N95 masks, cohorting, testing and isolation, and then finally vaccines and boosters. So let's look first at physical distancing. We're all pretty familiar with physical distancing, or sometimes called social distancing. This is where we do what we can to separate people by enough of a distance that we're reducing the risk of short-range transmission. And it's important to be really clear here that physical distancing is valuable, but only for reducing the risk of short-range transmission. In the context of schools, and particularly in classrooms, the practical things that we can do for increasing physical distancing are things like taking away clustering of desks and separating students to the extent that's possible so that they're spread out throughout the classroom rather than facing each other and breathing into each other. Just a note of caution though on physical distancing, there is no magical 1.5 metre or 2 metre distance beyond which people are completely safe. All physical distancing does is reduce the risk of close-range transmission, because the greater the distance, the more the virus particles are dispersed and diluted in that volume of air. Physical distancing does nothing to reduce the risk of long-range transmission. The next layered mitigation I'm going to talk about is cohorting. And this is simply where you ensure that you're avoiding situations where you're clustering groups of students together unnecessarily. And so cohorting is basically a measure to limit the likelihood of large COVID outbreaks. All you're doing is avoiding combining classes or having entire year level events, avoiding things like whole school assemblies where they're held indoors and where there might be a risk of COVID transmission, and avoiding large indoor gatherings, things like discos and graduation events, where they're in an indoor space, again, if there's not good ventilation. The next topic we're going to talk about as a layered mitigation is ventilation. So one way to think of ventilation is that the solution to indoor air as a medium for spreading of viruses like COVID is to make it as much like the outdoor air as we possibly can. By doing that, we help to dilute and disperse virus particles in the air, and that reduces the risk of long-range transmission of COVID. There are two types of ventilation, natural ventilation and mechanical ventilation. We're going to talk about each of those in turn. But it's important to note that ventilation doesn't do much to reduce short-range transmission. Again, that comes back to distancing, and we're also going to talk about masks as a means of reducing that risk. And when we're talking about natural ventilation, we just mean ventilation that's achieved by opening doors and windows and allowing air to flow through a space. So, as you might expect, if there is only one opening on one side of a classroom, you're typically going to get fairly poor ventilation because there's no flow through the space. If you have multiple openings, but they're on the same side, whether it's two doors, a door and a window or whatever, that's going to be better. If you have them on adjacent walls, it's likely that that's going to be even better. But the best sort of ventilation that we're looking for is where you've got openings on opposite walls. This is where, as long as you have a breeze, you have the ability for air to pass through that space and to remove virus particles from the air as efficiently as possible. Ceiling fans are also pretty effective in helping to mix the air. So as we said before, natural ventilation requires that you're dispersing virus particles in aerosols within an indoor space. And so ceiling fans can be a helpful way of improving that air mixing. The obvious thing to do to achieve good natural ventilation is to make sure that all doors and windows are open. It sounds fairly straightforward, but anecdotally what we're seeing is a lot of reports of classrooms where doors and windows are not open for several reasons, and we should talk about those. There are actually some fairly substantial obstacles to good natural ventilation. The first of those is if there's no breeze, then there's much less air movement that is taking the virus particles out of that indoor space and dispersing them out into the open air. So natural ventilation fundamentally breaks down on days where there is no air movement. Some classrooms don't have enough windows. In some cases, schools, for various reasons, including safety, have windows that can't be opened and they're sealed shut. Behaviorally, one of the biggest challenges is that someone actually needs to remember to open the doors and open the windows in classrooms. And this can actually be really challenging if the weather is really hot, or if it's really cold, or if it's windy, or if it's raining, or as we've had recently and will no doubt have more of, there is bushfire smoke. It's also difficult if there's a lot of noise outside the classroom. So natural ventilation is a really important part of reducing the risk of indoor COVID transmission, but for these reasons, it's actually a very limited lever that in some cases is very difficult to pull. One thing you can do if you're a teacher and for temperature reasons it's not possible to keep the windows all open all of the time, you can at the very least open some of the windows all of the time, and then every 30 minutes or so open the windows and doors, allow the classroom to flush out, get that fresh air in, and that's a reasonable way of balancing thermal comfort with the need to have good natural ventilation. Let's talk now about mechanical ventilation. We actually know that mechanical ventilation is highly effective, if it's working well, in reducing the risk of COVID spreading. So mechanical ventilation is where you have an inbuilt HVAC system that looks something like this, which is actually taking air from outside and pushing it into an indoor space to disperse and dilute the aerosols that people are exhaling. We know that mechanical ventilation greatly reduces the risk of COVID spreading, and I'm going to refer here to a study that was published in 2022, and it looked at the impact of different levels of mechanical ventilation on the likelihood of COVID infections in schools. And what they found was that the more air changes per hour that were achieved by the mechanical ventilation system, the greater the reduction in COVID infections. So an air change per hour basically means the entire volume of an indoor space is replaced with fresh air that number of times per hour. And so what you can see here is going from 2.4 air changes per hour to 6 air changes per hour delivered a really significant reduction in COVID infections. A note of caution, split system air conditioning units are not ventilation. As shown in this diagram, they do not bring in fresh air. All they do is recirculate the air that's already within a room. They either heat it or they cool it. But in terms of reducing the risk of COVID infections, split system air conditioning units have no benefit whatsoever. There are some obstacles to good mechanical ventilation. The first of those is that it could be turned off. Often this is for energy saving reasons. They can also be set to recirculate rather than to bring in fresh air. So it's important that you actually have an HVAC engineer inspect them, make sure that they're in good working order, and that they're set to bring in the maximum amount of fresh air rather than recirculating. We're going to talk next about CO2 monitoring. This is actually something that's a really helpful way of gauging the quality of ventilation in a shared indoor space. You may have seen devices, or you may use devices like this one from Aranet, which is a handheld portable CO2 monitor. It displays the CO2 level in parts per million, so 683 parts per million. Often they also display temperature and humidity. And a lot of these devices also have an accompanying app, so you can download the CO2 data over a period of hours or days or even weeks. The importance of CO2 monitoring is that CO2 is a good proxy for long-range infection risk. We know that because humans exhale a lot of CO2, about 40,000 parts per million. And so if you're measuring higher CO2 levels, that means you're breathing in more of other people's exhaled air. If there is high CO2, that means that there is poor ventilation because it's not removing that exhaled air that other people have put into that space. And if there's poor ventilation and you're breathing other people's exhaled air, that means there's a greater risk of COVID infection. It's helpful to look at different CO2 levels and to relate them to the quality of ventilation in a shared indoor space, and in turn to relate that to the risk of COVID infection in that space. So if we start off looking at outside air, if you take a CO2 monitor and go outside, you'll be measuring around about 420 parts per million of CO2. If you're in a shared indoor space like a classroom and the ventilation in that space is really excellent, you would expect to see CO2 levels between 420 and around about 600 parts per million. Between 600 and 800 represents acceptable ventilation. Ideally, we would have it under 600, but in many classrooms, 600 to 800 is pretty acceptable. Once you get to 800 to 1,000 parts per million of CO2, this is really a sign that the ventilation in that space is inadequate. And that means there's an elevated risk of COVID infection if there is someone in that space who has COVID. And it means there's some action required, either to improve the natural ventilation, to upgrade the mechanical ventilation, or to use something like a HEPA filter to augment the ventilation. And we'll talk some more about those things in a minute. If you're in a classroom where you're getting CO2 levels above 1,000, let's say between 1,000 and 1,500, this is really pretty concerning because it indicates that that's poor ventilation, and that equates to a high risk of COVID infection, and it really means actions required pretty urgently. And then if we go above 1,500, anything above 1,500 is really an indicator that that space has very poor ventilation. It's an extremely high risk of infection if there is someone who has COVID. And it really means that that space shouldn't be used and it should be evacuated. Interestingly, if you look at the studies into CO2 and its effect on cognition, we know for a fact that anything above around 1,500 ppm has a substantial impact on cognitive abilities. So not only is 1,500 parts per million a sign that there's a very high COVID infection risk, it's also a sign that students and teachers are not going to be able to function well because of the cognitive impact just of that CO2 that they're breathing in. If you ever get to CO2 levels that are up in the 2,000 or 3,000 range, this is actually quite hazardous. It can lead to severe drowsiness and pretty substantial cognitive impairment. There's been a lot of research done on CO2 levels and what an appropriate CO2 level is to reduce the risk of COVID and other airborne viruses spreading in shared indoor spaces. The consensus worldwide seems to be that in schools and other densely populated spaces, we should be having CO2 levels below 800 parts per million at all times, and preferably below 600 parts per million. There's now a dashboard being set up in Boston which tracks and reports the CO2 levels from 4,322 classrooms across Boston in real time. And so what this means is that anyone can go to this dashboard and see the actual CO2 level in each and every classroom in real time. And this is not just an important way of giving students, their families, and school staff confidence that the air they're breathing is clean and safe. It's also a great way of transparently showing that the school system has noted the importance of ventilation and of reducing COVID infection risk for the well-being of the entire school community. You might be interested to know that the air quality in Parliament House is very good. They have an exceptionally effective mechanical ventilation system that ensures that even in very busy meeting rooms and event rooms, the CO2 levels are constantly around this sort of level, 550 parts per million, which represents very low long-range transmission risk and means that everyone in that space is being kept very safe. I'm going to show you some CO2 charts that are taken from Australian classrooms over the last 12 months. And these are pretty representative of the sort of CO2 levels you might see across different schools in Australia. The first one is a well-ventilated classroom. So if you look at the CO2 levels on the vertical axis, during the course of the day from 8:30 through to 3 o'clock, it's pretty consistently below 600 parts per million. It gets a little bit above 700 just right at the end of the day, but this is about what best practice looks like in terms of having a really well-ventilated space. This is measured with the CO2 monitor sitting on the teacher's desk. Really important to note that you can't put a CO2 monitor mounted on a wall next to a window or near a door because it won't be representative of the air within the room. In contrast, this is what a poorly ventilated classroom looks like. So you can see during the course of the day, the CO2 levels increase from a low point of 400 and something parts per million. In the first class between 9 and about 10:15, they got up to 900, close to 1,000 parts per million. Later in the day, between 11 and 12, they got up to over 1,800 parts per million. And again, for two more classes, they were up at around 1,600 and then at over 2,000 parts per million. You can see from the shape of these slopes that the CO2 level increases over time. So this is a pretty clear sign that the ventilation is not allowing the CO2 and therefore the expelled aerosols from all the occupants of that room to be dispersed and removed from the space. And so what you would find is that if these classes went for longer, the CO2 levels would continue to rise. And at a CO2 level above 1,500 parts per million, as we discussed earlier, this is really hazardous. So this indicates a high risk of COVID infection, and really there should not be classrooms that have CO2 levels that are above that sort of 1,500 parts per million. And again, just to show a very poorly ventilated classroom, this is a school in which the CO2 levels have exceeded 2,000 parts per million in the first class and then over 2,500 parts per million. This is not just a really high COVID infection risk, it's a high infection risk for any airborne virus, colds, flus, and so on. And at that level, it also really is impacting the cognitive ability of everyone in that space. The next topic I want to talk about is HEPA air purifiers. HEPA stands for High Efficiency Particulate Air Filter. They're often referred to as air purifiers or sometimes air cleaners. And these are devices whose role is to filter out particulates from the air, and that can include dust or pollens, and it can also include virus particles. There are a wide range of HEPA filters available, and I'm going to talk through a few concepts. Important to say that I'm not advocating for the use of any particular type of HEPA filter or any brand or manufacturer, but what I will do is illustrate a few examples of commonly used HEPA filters that are available in Australia. I've used a student here just to give you a sense of the size of these things. And there are really two important measures to look at when you're assessing a HEPA filter. The first is the clean air delivery rate, or often called CADR. And clean air delivery rate is usually measured in cubic meters per hour. And what it represents is the volume of air that this unit can clean and deliver back into a space on an hourly basis. And so a large HEPA filter like the Smart Air Blast can deliver a CADR of around 680 cubic meters per hour. A medium-sized unit like the Samsung AX90 is able to deliver around 550 cubic meters per hour. Incidentally, the Samsung model that's shown there is the one that the Victorian government has rolled out across schools in Victoria. At last count, they had procured 111,000 of these units for schools. And then the last one there shown is another Samsung, the AX34, which is a quite a lot smaller clean air delivery rate of about 260 cubic meters per hour. There's a cost difference here, and cost is the other important consideration. There's a third consideration, which is the noise level. And so I've actually shown the clean air delivery rate for each of these at what's viewed as an acceptable noise level. There are quite a lot of HEPA filters that can be turned up to a very high fan setting, but where the noise really becomes distracting for students. We're lucky in Australia to have Clean Air Stars, which is a not-for-profit project that's created an air filter recommendation tool. There's a website that's linked there, and it allows anyone to go to this recommendation tool and to plug in the room volume, the number of air changes per hour that you're looking to achieve, and it will recommend available filters that you can purchase in Australia, and it will provide information on cost and noise levels and cater. And it's a really handy tool, so I'd encourage you to check it out. One of the questions that comes up often about HEPA filters is what's the cost? And so Clean Air Stars actually did an analysis on this recently where they looked at the most commonly used HEPA filter in Australian schools, which is the Samsung AX90. For a typical classroom, 2 of these would be required. They would be run on level 2 fan speed, which is at a noise level that's generally considered to be pretty acceptable in classrooms. And what they found was that when you factor in the cost of the unit, replacement filters over a 4-year time frame, electricity to run the units, for a typical classroom of 25 students, the cost to have these units in the classroom is around $23 per student per year. A couple of other practical points on HEPA purifiers. Quite a lot of units have an auto setting. Auto in this case means that it senses smoke or other pollution in the air. HEPA filters have no way of detecting viruses in the air, and so what happens is if you use the auto setting and there is no smoke, it decides that it'll put it on a very low fan speed, and this is obviously of no benefit if you're trying to actually remove viruses from the air. So you should never use the auto setting. It should be on as high as possible a fan speed for as much of the time as you can. There's no reason that you can't get students involved in helping with all of this. It's really simple to have a student on a roster basis asked to check every morning that the windows are open. Another student who's asked to make sure that the HEPA air filters are turned on and at the right fan speed. And you might have another student who's responsible for keeping tabs on the CO2 levels. Obviously important to make sure that it's still clear that the teacher is ultimately responsible for these things happen. But it's great if you can engage students. There are also some great learning resources that are available that can help students to get involved in understanding the importance of CO2, the importance of ventilation, and using it all as a learning opportunity. The next topic we're going to talk about is masks or respirators. This is an important topic, but it's also one that people tend to have strong opinions on. So what I'm going to aim to do is really just talk about what we know in terms of the science of the impact of different types of masks on reducing the risk of COVID transmission. Let's start with what masks are actually useful for. The first is they're really useful for source control. So we know that a large percentage of infections are from pre-symptomatic or asymptomatic carriers of COVID. And so what this means is that if you can have even a proportion of students in a classroom wearing a mask, you have a much better likelihood that you're going to be preventing infectious people from breathing COVID virus particles into that shared indoor air. Masks are really useful for preventing close-range transmission. Masks can prevent long-range COVID transmission in a poorly ventilated space. So the person you can see in this diagram on the right-hand side is someone that would be protected from long-range transmission. So as you can see, what masks are doing is 2 things. One is protecting the wearer by filtering the air that they're breathing and preventing them from inhaling virus particles. And they also protect others by reducing the likelihood of infectious particles being exhaled into the shared air by people who have COVID and are infectious, especially if they are pre-symptomatic or asymptomatic. Another study in the US that looked at mask wearing in schools found that for each 10% increase in the proportion of people wearing a mask, there was a 47% decrease in the probability of a COVID case in the following 5 days. So really what we're seeing here is that the more people who are wearing masks in a classroom, the greater the level of risk reduction. And importantly, you don't need 100% of people to be wearing a mask to get a very significant risk reduction overall. It's important to talk about different types of masks. And so let's spend a minute talking about surgical masks and comparing them with N95 masks. We all know what surgical masks look like. We saw a lot of them being used early in the pandemic. We now know that surgical masks are actually pretty ineffective in preventing people from getting infected with COVID. There's a couple of reasons for that. The first is that they were never designed for filtering aerosols. Surgical masks were designed to stop liquid splashes during surgery. They are a good barrier to fluids, but they're not a good barrier to aerosols. It's impossible to create an airtight seal between the mask and the face. They don't fit snugly. And so what happens is air leaks out between the face and the mask. And if the person has COVID, then the COVID particles enter the shared air. And if the person is trying to avoid getting infected, they can still breathe in infectious COVID particles around those gaps between the mask and the face. So surgical masks really are not effective in preventing COVID transmission. N95 masks we know are considerably better. There's no such thing as a perfect mask, but they're called N95 because they filter out at least 95% of small particles. So N95 masks offer pretty high COVID protection. They were designed to filter aerosols, and we'll talk a bit more about how they do that. But importantly, a well-fitting N95 mask actually provides a fairly airtight seal between the mask and the face. And this means that there's very little leakage. And so almost all of the air that the person is inhaling and exhaling is filtered through this N95 filter material. There have actually been some studies done to look at the quantitative difference between surgical masks and well-fitting N95 masks. And this is a study published in 2022 that shows the relative risk of COVID infection when you have two people wearing surgical masks versus two people wearing an N95 mask. What they found, in short, was that there was a 75 times risk reduction when you went from just wearing surgical masks to both people wearing a well-fitted N95 mask. So that's a massive difference. The next thing to say about masks is that they're only effective if it covers your mouth and your nose. And unfortunately, it's pretty common to see people wearing a mask that either covers their mouth and not their nose, or just wearing it underneath their chin. Obviously, this doesn't do anything. It's also worth knowing that if you're a man and you have a beard, that is actually a significant obstacle to your mask doing a good job. What's happening, the longer your beard, the worse it is, but what's happening is effectively the air will preferentially go between your face and the mask rather than be filtered through the mask. A question that sometimes comes up about N95 masks is, are they expensive? The reality is that they're really not. They are more expensive per unit to purchase, but they can be used many times. So this is the 3M Aura mask, which seems to be the one that most consistently people find is a good fit and is comfortable. We can buy them in Australia in boxes of 20. They work out to be about $3.40 for each mask, and they can be used 10 to 20 times each. As long as the mask isn't showing obvious signs of wear and tear and it hasn't got any holes in it, then you can reuse it many times over. There are unfortunately some obstacles to mask wearing. The first of these is that sadly masks have been stigmatized by some politicians and even some doctors, despite the fact that there's really compelling evidence that they're an important tool in preventing COVID transmission. There's also been some misinformation about the effectiveness of masks, but as I've said before, there's now some very compelling research from all around the world that shows that N95 masks are in fact very effective in preventing COVID spread. Comfort can be an issue, but it tends to be more of an issue for people who are wearing ear loop masks, and you'll find generally that when you upgrade to a head strap type of N95 mask, it's a much better and more comfortable fit, as well as being more effective. Teachers can be a really positive role model when it comes to normalizing and destigmatizing mask wearing. Whether a teacher wears a mask in a classroom or in other high-risk settings, just the act of wearing a mask is a really helpful way of communicating to students that it's an okay thing to do. It's a good idea if you're in a time of high COVID transmission. And it sends a really positive signal that it's okay to wear a mask to protect yourself and to protect others. A really important part of the layered mitigation strategy is testing and isolation. So we're going to spend a couple of minutes talking about the different types of tests and what they mean and how to use them, and what that means in terms of people isolating if they do get COVID or they have a family member with COVID. Let's look first at rapid antigen tests, or RATs. We're all pretty familiar with these. One really fundamental challenge with RATs is that currently we're seeing a false negative rate of around 60%. So what that means is that if someone has COVID and they do a RAT, the odds are that the RAT will fail to pick up a COVID infection 60% of the time. So that's a massive false negative rate. Doesn't mean that RATs aren't useful. Their accuracy improves as someone's COVID infection progresses, but early in a COVID infection, it's not uncommon for someone to do one or even multiple RATs and get negative results, only to then do a later RAT test and find that it becomes positive. So what it means is that there are a lot of people who are getting a negative test result, but who do still have COVID and should be isolating. It's more likely for people to test positive after 3 to 5 days, so it's really important to keep doing RATs if you have symptoms. If you do have those symptoms, you should assume that you have COVID and isolate, and then test again the next day. And ideally get a PCR if that's available to you. The good news with RATs is that the false positive rate is very close to zero. It's estimated to be about 0.1%. So what that means is that if you get a positive result on a RAT test, it's very likely that you do in fact have COVID and that you are infectious. We all know what a positive RAT result looks like. It's the 2 red lines on the test kit. Unfortunately, for some people, their positive result isn't as clear as 2 dark red lines. This is a positive result. So the test line is a faint pink line, but it's still visible. That means that person has COVID. And this one, almost invisible, but there is still a faint pink line as a positive result. And so it doesn't actually matter how faint the line is. If it's there, it's a positive result. A number of doctors have pointed out that people may be getting false negative results from their RAT tests because they're not doing a great job of sampling. And so I'm going to play you a really short video from Dr. Eric Levi, who's an ear, nose and throat surgeon, explaining how to do a RAT test effectively so that you actually get the most accurate result possible.
My name is Eric Levi. I'm an ear, nose and throat surgeon from Melbourne, Australia. I've got 2 things that I want to tell you about the nose. Firstly, the nose goes back, not up. So if you were swabbing in this direction, you are going to hit the narrow roof. It's painful. Don't do that. The nose goes back and down. Secondly, I see a lot of people doing something like this. Now, that's not great sampling. That is just swabbing the hairy skin of the nose at the front. What we want to get is the mucosa, the respiratory lining of the nose, which is down and back. So please go flat, aim backwards, and go slow, go low. And that would be the way. About 2 to 3 centimeters around the back, go low and go slow, and then you can twirl for 15 seconds, and then you pull it out.
Okay, so you can see that sampling is really important, and doing it well will give you a more accurate test result. The other thing we've started to see is reports of people who found that when they swab just their nose, they're getting negative results, whereas if they swab their nose and their throat, they get a positive result. In this example, it was a weak positive from the nose and a strong positive from the nose and throat. Probably better to do the throat first and then the nose, be my suggestion. But this is actually backed by some research. There's a study linked here, which was published fairly recently, that shows that there are large differences in the viral loads from different points of sampling, and that there are actually some good reasons to combine throat and nose sampling in order to get the best possible result. Okay, so when should you use a RAT test? Obviously, if you have symptoms that could be COVID, then that's a time to use a RAT. If you have been exposed to a known positive case, so if there's been someone in your class or your household or your workplace who's been a known COVID case, even if you don't have symptoms, bearing in mind that a lot of people are COVID positive but asymptomatic, then that exposure should be a trigger for doing a RAT test. If you're living with someone who has COVID, you should be doing regular rat tests to identify if you do get COVID from that person. It's a really good idea to do a rat test before going on a school camp or any other high-risk setting where you're placing large numbers of students and staff together on things like bus trips. And it's a really good idea for schools to not just encourage families to do that, but to make the rats available so that there's really no barriers to having all participants in that trip testing to reduce the risk of someone going on the camp and unknowingly showing up and infecting a whole lot of others. Also, before visiting high-risk relatives, as we said before, a significant percentage of the population are at higher risk if they do get COVID, and so it's really helpful to identify asymptomatic or pre-symptomatic infections before you go and visit those high-risk people. And also, very importantly, it's useful to use a rat test when you've had a COVID infection to tell when you are no longer infectious. And we'll talk some more about that in a minute or two. We should talk about PCR tests. PCRs are pretty valuable because they have a much lower false negative rate than rat tests, around about 5% on average. So this means that if you test negative on a PCR, it's pretty likely that you don't have COVID. They also have a reasonably low false positive rate of somewhere around 2%. So that means that if you do test positive on a PCR test, it's very likely that you do in fact have COVID. The challenge with PCR tests, obviously, at the moment, is that it's much more difficult to get them, and for the most part, it requires a referral from a GP. If we think about how long people are infectious for, this is an area where there's actually quite a lot of misinformation. There have been studies that have shown how long people are infectious for on average, and we now know that around 75% of people are infectious for more than 5 days. Around 50% of people are infectious for more than 8 days, and 25% of people are infectious for more than 10 days. So this is really important when it comes to ending isolation. People should end isolation, obviously, when they've stopped being infectious, not at some arbitrary number of days. So here's a simple chart that just shows a timeline for somebody who becomes infected with COVID after an exposure. So exposure here is at day 0. Typically, people have an incubation period which might span 1 to 3 days on average. At some point in that incubation period, they become infectious, and they're typically infectious, as we just saw, for a range somewhere between 5 and 14 days in total. They typically become symptomatic after they're infectious, and they're symptomatic for as little as 0 days, because as we've said, there are a significant proportion of people who never develop symptoms. But if they do develop symptoms, they can last for typically up to around 14 days. And people are rat positive typically for about 5 to 12 days. So what this all means is that there are a couple of important time periods that we really need to be thinking about. The first of that is pre-symptomatic transmission, when people are infected and infectious but are not yet symptomatic. So pre-symptomatic transmission occurs in this period of time, which may be a day or more than a day, where people are in fact infectious, but they just don't know it. The other important category of transmission is people who are asymptomatic, so they never develop symptoms, but yet they are infectious for that whole time. Lastly, if you remember back when we talked about the layered mitigations that we can combine to have a positive effect on reducing COVID transmission, the layer that sits across all of that is effective communication. Unfortunately, what we're seeing in Australia, in not just the media, but also in the political sphere, is a lack of willingness to talk about COVID. And unfortunately, this seems to have filtered through in some school communities to really having schools in a situation where they don't feel that they can really raise the issue of COVID. And this is really not helpful. So if you have this situation where the school or families don't want to hear about COVID, it actually undermines all of the other efforts that we've talked about in terms of the layered mitigations. It's understandable that schools and families are really fed up with hearing about COVID. We all are. But it's actually counterproductive to not talk about it, because it prevents people from taking rational actions to protect themselves and to protect others. So a few practical things that schools can do. The first is to really just set out to candidly communicate with families about COVID, to talk about the health risks, talk about the science and what we now know about COVID, and talk about what the school and what families can do to reduce COVID transmission. Schools shouldn't be setting out to alarm people about COVID, but equally they shouldn't be downplaying or trivializing the risks, really just setting out to communicate the facts and ensure that families are equipped with enough information that they can take reasonable steps to protect themselves and protect others. It's a good idea to host an information session for parents so that they can ask questions, to encourage families to take steps themselves to reduce the risk of getting infected in the community. And that includes talking about wearing masks, why N95 masks are a better choice than surgical masks. Make COVID safety an obvious part of the school's culture, so you're really talking about it as if you were talking about an important safety issue, because that's what it is. It's a good idea to develop and publish a COVID risk management plan on the website so that you can actually demonstrate and communicate the steps the school is taking, and just make sure that you're covering it in newsletters, emails, assemblies, and so on.